Good evening, everyone. I am Dr. Rashmi, second year PG resident in medicine. Here, today I will be presenting a case titled as Myositis to be or not to be under guidance of Professor Dr. Sumit Sigla sir. A 27-year-old unmarried lady, resident of Delhi, presented with chief concerns of difficulty in climbing stairs and getting up from a squatting position for 2 years. She had 2 year history of progressive difficulty in climbing stairs and rising from a squatting position, which was insidious in onset and gradually worsened. Her weakness was limited to the lower limbs only. There was no muscle pain, muscle wasting, fasciculation, cramps, or any diurnal variation of symptoms. She did not have any movement disorder, autonomic, or sensory disturbances. There was no facial deviation, bulbar involvement, or any visual disturbances. She did not have any fever, any symptoms suggestive of connective tissue disorder or autoimmune diseases. There was no history of any drug intake, no exacerbating or relieving factor for her weakness. System reviews were unremarkable. She was third of five siblings born out of a non-consanguineous marriage. All siblings were apparently healthy. No known family history of similar complaint and neuromuscular disorders. Her other histories were unremarkable. Her general physical examination was normal with stable vitals. Her neurological examination, cranial nerve and sensory system was normal. Power of muscles of the upper limb was normal. Power in proximal and mid group of lower limb muscles was MRC grade 4 out of 5. There was no associated muscle atrophy or hypertrophy. Tone and DTR were normal. No fatigability in muscles were observed. Other systemic examination was also normal. This table depicts weakness in proximal and mid group of lower limb muscles along with marked weakness in distal muscles also. Her routine baseline investigation, including inflammatory markers, were normal. Her muscle enzymes were significantly raised with raised LDH. Thyroid function, ANA profile, and 2D echoes was normal. Myositis and autoantibody profile was also negative. EMG suggested of myopathic pattern of weakness. MRI bilateral thigh showed fatty infiltration of muscles, suggestive of active inflammatory process. On the basis of above, our preliminary diagnosis was of inflammatory myositis, specifically polymyositis. But some red flags were there. She had onset of symptoms at relatively young age. Normally in polymyositis, symptoms begins at age of 33 to 36.5 years. She had protracted course of weakness. Her weakness was limited to legs only. And she also had selective weakness in distal muscles also, which were very unusual for polymyositis. All autoantibodies was negative with normal inflammatory markers. There was no systemic involvement like skin, lung. All these features made us to reconsider our diagnosis, and we decided to perform a muscle biopsy. Muscle biopsy showed dystrophic architecture with variable muscle fiber size. No evidence of inflammation was seen in muscle biopsy. On immunohistochemistry, there was dysplasin expression was absent. Here we can see this is normal dysplasin expression. This is patient with dysphalinopathy with absent dysplasin. Bottom slides are showing variable muscle fiber size. After muscle biopsy, we made our final diagnosis of limb-girdle muscular dystrophy type 2B, also known as dysphalinopathy. It is an autosomal recessive disorder. Caused by the mutation in the DYSF gene leads to deficiency of dysplasin in sarcolemma, which is key for memory repair, cell adhesion, and calcium signaling. There is used interfamilial and intrafamilial phenotypic variability seen in dysphalinopathy, which can lead to different clinical phenotypes, ranging from asymptomatic hypercemia, which is very milder form, limb-girdle muscular dystrophy type 2B, which is characterized by proximal muscle weakness, typically in pelvic and shoulder girdle muscle. And in Miyoshi myopathy, there is distal muscle weakness is seen specifically in gastrocnemius muscle. Other phenotypes are distal myopathy with anterior tibial onset and mixed proximo-distal variant. Dysphalinopathy is most common autosomal recessive LGMD in India, excluding the Agarwal community, where capillopathies are more common. Symptom onset usually at adolescence to young adulthood. Proximal muscle weakness seen in LGMD type 2B and distal muscle weakness seen in Miyoshi myopathy, leading to difficulty in standing on tiptoes. Respiratory muscle involvement can be seen in 20 to 30% cases, but facial and cardiac muscle involvement are uncommon. Combination of clinical evaluation, electromyography, Western blot, and genetic screening are essential for accurate diagnosis. Treatment of dysphalinopathy is mainly strengthening exercise, uh, physical medicine, rehabilitation, patient's awareness, and prenatal counseling. Avoidance of corticosteroids is very important because they can worsen muscle damage. Life expectancy in LGMD type 2B is generally normal. Now, what are the challenges in the diagnosis and treatment of dysphalanopathy? In our case, we were vigilant to avoid administer steroid before the confirming our diagnosis to avoid any harm to patient. However, literature showed that around 16 to 25% cases of dysphalanopathy were misdiagnosed as polymyositis. Similarly, a systemic review spanning over 20 years showed 32 cases of dysphalanopathy was misdiagnosed as juvenile polymyositis. This is due to its this is due to its considerable genetic and phenotypic heterogeneity alongside overlapping clinical and histological features with inflammatory myositis. Now the question arises, when should we suspect myositis mimic? Some clinical features that can help to identify some potential myositis mimic, such as young age of onset, slow progression of weakness, multi-system involvement, significant family or drug history, worsening of weakness after repetitive muscle movement,
1 minute
asymmetry
left.
of muscle movement, involvement of our distal muscles also, and lack of response to steroid therapy. If any one of these is present, we should consider alternative diagnosis other than inflammatory myositis. What are the learning points from our case? Beware of misdiagnosing dysphalanopathy and avoid corticosteroids. Always start evaluation with the premise my patient does not have inflammatory myositis. Exclude myositis mimics. Don't be in a hurry to start steroids. When in doubt, always do a muscle biopsy and ask for special stains. Except perhaps in dermatomyositis cases or connective tissue disorder, connective tissue disease overlap inflammatory myositis cases. Um, Always ask for special stains because MRI, electromyography, and muscle biopsy with plain stain can be both inflammatory myositis and LGMD type 2B. For gene mutation analysis, always ask for whole exome sequencing by next generation sequencing. Dysplain protein also
Time's
present
up.
in peripheral blood mononuclear cells. If in cases where muscle tissue is not available for biopsy, we can do western blot in peripheral blood. Here, the Gen Foundation provide testing for dysphaline throughout the India. It also offer a very interesting tool, automated limb girdle muscular dystrophy diagnostic assistant tool, which can determine the probability of likely diagnosis on the basis of clinical feature and investigations. According to this tool, our patient likely diagnosis was dysphalanopathy with very high concordance. These are the study conducted in India on LGMD type 2B by Khardlikar V et al. And Nalini A et al. This is very well written article on myositis mimics. We all should read these articles for better understanding of myositis. Thanks to Myositis in India for this opportunity. Happy learning.